So those are our objectives today: better understanding of benzodiazepines and how they work, and understanding the proper use of them. So benzodiazepines haven't been around that long. They were developed in the 1960s, and actually they were discovered by accident in about 1955 by a chemist who was working for La Roche, which is a drug company, which is still a drug company today. So he sort of discovered this by accident, and they used it to start treating patients for anxiety, and they started to realize that it worked for seizures as well. And they quickly discovered a whole bunch of other benzodiazepines. So the first one that they sort of discovered by accident was called Librium, and shortly after that they discovered diazepam or Valium. And so by the mid 1970s, benzos were like the most highly prescribed drug on planet Earth. And they used a lot of benzos to replace the use of barbiturates. Barbiturates were also anticonvulsant drugs, but the reason they like benzos better is benzos have a much wider therapeutic index. So they're a lot safer drug to use than barbiturates. Barbiturates tend to be easier to overdose on. They're a little easier to become addicted to than benzos are. Not that benzos aren't, but they're a lot safer than barbiturates were. So they quickly replaced the use of barbiturates. We still see barbiturates being used today, but not nearly as much as benzos. We like benzos because they have a lot of different properties. They're anxiolytics, so they help with anxiety. They're hypnotics. They're myelorelaxants, so they relax muscles. They're an amnesic, which is beneficial when we're doing sedations. And then, of course, they have anticonvulsant properties, so they're good for things like seizures. Some of the more common ones that we see are Lorazepam, diazepam, clonazepam, Midazolam, and Temazepam. Those are probably the more common ones, but there's a whole list of benzodiazepines. It goes on and on and on. So how benzos work? So, whoops, what's going on here? Okay, so before we understand how benzos work, we kind of need to understand action potentials and how neurons send signals in the brain. So just a really, really brief summary of the anatomy of a nerve cell. So I don't know if you guys can see my mouse here. The cell is made up of, to start here, dendrites. So these are the finger-like projections you see here. And these are what we call postsynaptic dendrites. And they receive signals from other neurons to the cell body or the soma. From there, the signal is sent down the axon here, which is covered in these myelin sheaths, to the axon terminals, which send the signals on to the next neuron. Okay, so very brief, very simple. That is basically the anatomy of a neuron. So neurons send signals through action potentials, and they send it by using electrochemical signals. So basically, it's chemicals that are creating an electrical current. The most important ions that are used in this is sodium, potassium, calcium, and chloride. Today, we're going to talk mostly about sodium, potassium, and chloride. Calcium is more prevalent when we start talking about action potentials in heart. But the sodium and potassium and chloride are sort of the three main ones. And then there's also some negatively charged proteins, which we'll talk about in a second. But these are sort of the main players in an action potential. So the membrane of a neuron is semi-permeable, which means it allows some ions in and some out, but blocks others. And it does this specifically so that it can transmit these electrochemical signals. So if you look at the picture here, there's a layer of membrane. It's a or a bilipid layer. And inside that layer, there's like these three proteins. And those proteins are what we call ion channels. And they allow the passage of specific ions in specific amounts in and out of the cell. And that's what helps potentiate this signal from one neuron to the other. So if we're looking again a little bit closer here, there's this phospholipid bilayer, and these proteins here in the middle that are allowing the passage of ions. On the inside of the cell, we have a high concentration of potassium, and on the outside of the cell, we have a higher concentration of sodium. Okay, and through the action potential, that's going to shift, which is what's going to create the signal that we're going to talk about in a little bit here. So at rest, your neurons are negatively charged inside and more positively charged on the outside of the cell. And it's that difference in charge that is sort of the staple of where an action potential can actually start. So at rest, the inside of the nerve cell is negatively charged relative to the outside, because inside the cell we have these negatively charged proteins, which they really can't move in and out of the cell. They're stuck in there, but they help generate that negative charge inside the cell. Potassium is more prevalent, like I said earlier, inside the cell, but it can travel across the cell membrane through its ion channels. Chloride is more prevalent outside the cell than it is inside the cell at first. And sodium is more prevalent outside the cell than it is inside the cell. These two can also move and do move throughout the action potential, and we'll talk about that in a second. But overall, the cell is more negatively charged inside because of these negatively charged proteins and a little bit of chloride that's in there. So the concentrations of the ions are going to try to balance themselves out. So anytime we have more of a concentration on one side of a cell membrane than the other, that concentration is going to try to push its way towards the lower area. So for example, if we go back up here, this chloride is going to try to push its way into the cell, and this potassium is going to try to push its way outside of the cell in order to balance out the amount of potassium on both sides. The only things that are preventing them from doing that are these ion channels that block or allow the passage of these ions, and the electrochemical charge. So the balance of the electrical charge on both sides is what helps keep things where it belongs. And of course, those proteins are what helps keep things in or out of the cell. So the reason they can't get in and out of the cell just on their own is because of these selective ion channels. And that's really important when we start talking about how action potentials actually happen, because if your electrons could just or the ions could just make their way inside and outside of the cell whenever they wanted to, we wouldn't be able to actually conduct that electrochemical signal anywhere, because your nerves would just be constantly firing all the time. You'd basically be in a seizure at all times. So at rest, the inside of the neuron has a negative charge of about minus 70 millivolts compared to the outside. So it's 70 millivolts lower than what's on the outside of the cell. And we call that the resting membrane potential. So when your cells aren't firing, they're roughly at this minus 70 millivolt level. Okay, and that is the resting membrane potential. So when the cell is at rest. So because of the difference in charge between the inside and the outside of the cell, which is called the electrical gradient, because it's different on both sides, we say that the cell is polarized. So the inside being negative, the outside being positive, you have a polarized cell membrane. So much like a magnet is polarized because it has a north and south, right? Or if you have two people with completely opposite views, we say they're polar opposites. The cell here is polarized because it has a negative charge on the inside versus on the outside, okay? This is maintained at rest with those sodium and potassium pumps. So like I said before, the potassium would try to flow outside of the cell if it could, but these pumps keep it inside, and the chloride can't flow in, and those proteins are stuck in there. They can't just go through the cell membrane, and the sodium is the same. So it's these pumps that help sort of keep things in check, right? Now, from rest, there's basically three options for your neuron cell membrane. It can either maintain at rest and stay at that minus 70 millivolts. It could be hyperpolarized, meaning we can make it even more negatively charged. So for example, bringing it down to like minus 85 millivolts. Or it could be depolarized, so decreasing the negative charge towards 0 millivolts, so making it more positively charged. Hyperpolarization happens when an inhibitory neurotransmitter touches a neuron. So it inhibits that neuron from being able to fire. And a depolarization happens when an excitatory neurotransmitter touches that nerve. So it makes it increase its charge and causes an action potential. So those are your three options. You can either stay at rest, you can hyperpolarize, or you can depolarize. Sorry, say that again. Okay, I'm just getting feedback. Okay. Action potentials are caused by depolarizing currents. So when one nerve cell fires, it sends a signal down its axon to its axon terminal. And from there, an excitatory neurotransmitter crosses the synapse to the next cell. Now, when that excitatory neurotransmitter touches that next neuron, it causes that neuron to depolarize and sends the signal down to the next neuron. So it's sort of a chain reaction kind of thing. A stimulus causes the resting membrane potential to move up towards 0 millivolts. And I've got a couple of diagrams that will sort of help explain this. If the stimulus is strong enough to depolarize the cell to about minus 55 millivolts, the neuron will actually fire an action potential. That level is called the threshold level, or the threshold potential, or the action threshold, depending on what textbook you're reading from. So it's the level at which that cell sort of decides, okay, now's the time we're going to fire. If the neuron doesn't get to that minus 55 millivolts, it doesn't fire at all. If it reaches that threshold, it will always fire, and it fires a fixed action potential. So it's kind of an all or none thing. One of the questions we get once in a while is, when people are in a lot of pain, does that mean their nerves are firing harder? No, nerves can only make a signal go a certain way. So they have a fixed action potential size, and they can send a signal one way and one way only. So it's all or nothing. It either reaches that threshold and fires, or it doesn't reach that threshold and it doesn't fire. What causes more pain for people is not how hard the nerves are firing, but how rapidly they're firing and how many nerves are firing. So if I have a small cut on my hand, I'm going to have some nerves that are feeling that, and they're going to send me signals saying this hurts. If I have a large laceration that's really deep, I might have more nerves that are sending me signals, and maybe they're sending signals a lot faster, which creates a greater pain sensation. But the individual neuron itself isn't firing harder, it's just firing faster, and it has more friends giving me the same. So it's all or nothing with a nerve. Okay, so at rest here, this minus 70 millivolts, okay, this is your resting membrane potential, okay? So this is where your nerves are sitting when nothing is happening, which is very brief moments in time in your system. As the level increases, we get up to what's called this threshold level here. So right at this point where you kind of see where it sort of starts to increase, right here is where sodium channels start to open. So a signal has been sent to that nerve. It opens up some sodium channels, and sodium starts to make its way into the cell. Now, as sodium enters the cell, because sodium is positively charged, it increases the amount of charge inside that neuron. And if we can increase it to the point where we reach that threshold level, we're going to get that sudden impulse, that spike that happens in the neuron. So this spike is your action potential right here, okay? So if you can get your level up to the threshold, it's going to cause a sudden spike. So when it reaches that threshold and it fires, more sodium channels open up, and you get that sudden huge increase in the voltage inside that neuron. Once you get to the top, those sodium channels close, the potassium channels open, and all the potassium that's inside the cell, which is also positively charged, starts to dump out of the cell. And that's what helps bring the charge back down to normal. In fact, it even goes below normal. It hyperpolarizes, gets down below that -70. And then from there, those channels close, and there's a group of channels, ion channels, sodium potassium pumps that actually require energy, will start to actively pump sodium back out of the cell and potassium back into the cell, and gradually return that gradient back to where it was at the resting potential. Okay, and all this happens in a matter of about 6 milliseconds. Okay, so if you had an EEG, I don't even know if it wouldn't really show like this, but if you had a machine that could show you a graph of what an action potential looks like, it would be like the signal you're seeing here in the red. Now, this would be the action potential for a nerve cell in the brain. If you look at an action potential of a cardiac muscle cell, it has a slightly different shape. Once you get to the top, it kind of plateaus for a bit and then makes its way down. That's, again, to allow time for blood to actually move and circulate and stuff. And there's some calcium channels that are involved in it that sort of create that plateau phase. So we're not going to talk about that today, but if you're seeing action potentials online, if you're looking up action potentials and you see sort of a plateau-shaped one, kind of looks like ST segment elevation, that is an action potential for cardiac muscle, okay? So at rest, we're at that -70 millivolts, and we get a signal from somewhere else, an impulse from another cell, and it's an excitatory impulse. So sodium channels open up, and you can see right here where the yellow starts. This is where the sodium channels open, and we increase the voltage inside that cell to about -55 millivolts, which is the threshold level. And if we reach that threshold level, more sodium channels will open up when we get to this green section. That causes a huge spike in the voltage inside that cell, because remember, inside the cell is full of potassium, which is positively charged. And then now sodium is rushing into the cell, increasing that charge even more so. So that's why you get that sudden big spike. Now, just knowing this much about action potentials, you can actually understand how a different drug works, and that's lidocaine. Lidocaine is a sodium channel blocker, and so it's used as a local anesthetic. Because it blocks sodium channels, we never really get to this point here. So the voltage can't increase because those sodium channels are blocked. Sodium can't make its way into the cell, and so it never gets to threshold and it never fires. So when we're using lidocaine as a local anesthetic, let's say you're getting dental work done or you're getting sutures or something, they'll inject lidocaine around the area to numb all those nerves. And what they're doing is they're actually blocking all the sodium channels in those nerves, so they can't receive signals. So they don't feel any pain, and the brain doesn't send them any. So there's no efferent or afferent going on there. So that's why you get numbness from using lidocaine. It's a sodium channel blocker. So it prevents action potentials from happening. Okay, from there, once we get to the top here and we've maxed out, the sodium channels will close, and now we're super depolarized here. And so the potassium channels open up, and the potassium starts to spill out of the cell. And that's where we get this sudden decline here, to the point where it actually hyperpolarizes. It becomes more negatively charged than usual. And then from there, the potassium channels will close right about here, and those pumps, those sodium potassium pumps, will actually actively pump using energy. They'll pump the sodium out of the cell and the potassium back into the cell until we get back to that resting membrane potential here. Okay. So far, so good. I haven't lost anybody or bored anyone to death. I promise you this will all make sense in a minute. Okay, so again, we've got our resting potential. We have an increase, right? Sodium channels are opening up here. We reach that threshold potential, and now the cell depolarizes here. Okay, so this is what you call the action potential, this actual firing, this impulse that's created here. From there, we have the potassium channels that open after the sodium's closed, and it repolarizes the cell. and actually hyperpolarizes it down here until eventually the potassium channels close and the pumps take over and put everything back where it belongs. This area here, this action potential area, this is also known as the absolute refractory period, meaning the period in which there's nothing we can do to create another stimulus in this cell because it's in the middle of firing an impulse. So in this period right here, we cannot stimulate this cell again. Beyond that is the relative refractory period. And the relative refractory period is when the cell could potentially be stimulated again, but it would have to be under the right conditions and would have to be a fairly large stimulus. So for the most part, the refractory period is the period of rest for that nerve cell. So you can see from the beginning of the stimulus to repolarization, you're looking at about 6.5 milliseconds. So all of that we described over the last 10 minutes, 20 minutes, happened in 6 milliseconds. So it's amazingly fast. Okay, actually, this one describes the refractory period. So once you hit the threshold potential, you're into the action potential zone, which is also the absolute refractory period. So nothing can happen in this neuron now because it's in the middle of sending an impulse. In the relative refractory period, you could potentially get another signal to happen, but it would have to be under the right conditions, and it usually doesn't happen. So. Okay, so any questions so far? I'm going to take that as no's. Okay. Now, that signal is propagated all the way down the axon. Okay, so it starts at the dendrites, which receive the signal, and if it's an excitatory signal, sodium will start to enter the cell at the cell body. Okay, and that'll create that initial elevation of the voltage, and hopefully for the cell, if that's what it wants, get it up to the resting or the threshold potential to create that signal to fire. Now that happens all the way down the axon. So you can see this is sort of at rest here at the top. This is a resting axon. A stimulus is applied, and you can see the sodium making its way in, and then eventually potassium making its way out as we're doing the cycle of the action potential, and then that propagates. It happens all the way down the cell, right? All the way down the axon of the cell until it reaches the end, the terminals. Okay. When the action potential reaches the terminal, the presynaptic terminal, it causes a neurotransmitter to be released from the neuron into the synaptic cleft. So the synaptic cleft is, I don't know if you guys can see me. So these are the terminals here, and then there's a space right in between, and then you've got the next cell which has its little feelers out there, the dendrites. And so when this cell fires, it sends these neurotransmitters out into the synaptic cleft, and they float through, and then they attach to the dendrites on the next cell. Okay. The neurotransmitter might be an excitatory neurotransmitter, or it might be an inhibitory neurotransmitter, depending on the type of neuron that's releasing it. So we have specific neurons that send excitatory messages. We have other neurons that send inhibitory messages. And you need both. You have to have both all the time working against each other. So it's kind of like insulin working against glucagon. We're constantly releasing insulin and we're constantly releasing glucagon, and the two work against each other. So insulin is always causing the uptake of sugars, and glucagon is always causing the glycogenolysis and creating more glucose for your body, so they sort of work against each other. If you only had insulin working all the time, you'd be hypoglycemic constantly, right? You'd constantly have to be pushing sugar into your body. And if you only had glucagon, of course, you'd be hyperglycemic, you'd be diabetic, right? You'd be a diabetic. So you need both working against each other all the times to balance, to create that homeostasis. It's the same thing in your neurons. You need excitatory neurotransmitters and you need inhibitory neurotransmitters. If we only had excitatory neurotransmitters, you would be in a constant seizure, basically. All your nerve cells would be firing all the time. Too much excitatory neurotransmitters can lead to things like Lou Gehrig's, right? So it's that balance. You need both going all the time. So we have nerves that do one and nerves that do the other. So depending on the type of neuron releasing it, it could be an excitatory signal or an inhibitory signal. So the top one here is the first nerve that's fired, and this is the terminal at the end, so the presynaptic terminal. This here is your synapse, this gap in between. And then this is the postsynaptic dendrite that's going to receive the message, okay? So the signal gets sent down, and this neurotransmitter gets released, and it floats over to the receptors on this dendrite, and it creates the signal for the next neuron. Now, if this is glutamate, for example, which is excitatory, it's going to attach to this cell, and it's going to cause this cell to open up its sodium channels and allow sodium to come in and cause an action potential in that cell. If this was GABA, for example, which is inhibitory, it would attach to these receptors and cause chloride ion channels to open up, bring chloride into that cell, make it more negatively charged, and make it even harder for that cell to fire. So it inhibits that cell from firing its message. Okay? So if excitatory neurotransmitters are released, positive ions will travel to the next neuron, and they'll bring it towards that threshold potential. And if inhibitory neurotransmitters are released, then you get negatively charged ions, specifically chloride, and they'll travel into the cell and hyperpolarize it. They'll make it even more polarized than it was before. So we have a number, there's hundreds of neurotransmitters. The more common ones that we talk about are acetylcholine, which is used mostly in like in muscles, right? So it's usually for muscle tone and contraction of skeletal muscles and that sort of thing. The dopamine is another one. You guys have all heard of dopamine for sure. That's sort of your that's like a pleasure chemical is what they call it. And it's released when you get like a reward. So it's like if you really like chocolate and you haven't had it in a while and you eat some chocolate and you get that, oh yeah, that feeling, that's dopamine being released. It's kind of it's like a motivating neurotransmitter, right? So anytime you get a reward, you get that release of dopamine, whatever makes you happy, if it's running or exercise or, watching your favorite TV show or food or whatever, you get that dopamine release, makes you feel good. There are specific drugs that actually inhibit the reuptake of things like dopamine. So what I mean by that is, if I go back up to this picture here, once this neurotransmitter is released, this neuron up here is going to reuptake that neurotransmitter. It's going to take it back, right? So we send the signal, and okay, come on back. It takes back that neurotransmitter. So we call that reuptake. So there are specific drugs that actually prevent the reuptake of neurotransmitters to create an effect. So, for example, cocaine is a dopamine reuptake inhibitor. So when people take cocaine, it prevents dopamine from making its way back into the neurons, so that dopamine is constantly causing these cells to create this good feeling, right? Glutamate is the principal excitatory neurotransmitter in the brain. It's the most excitatory of them. It's used mostly for like learning and memory, and other functions, anything to do with excitation. So certainly seizures can be caused by glutamate if there's nothing to counterbalance it, right? Too much glutamate, though, we talked about earlier, it can lead to things like, or it can be caused by things like stroke or Lou Gehrig's disease. And so you'll see those patients with the tremors and the dysfunction or the neural dysfunctions, right? Because they have too much glutamate and nothing to stop it. Serotonin is another really common one. It's sort of a calming chemical. So this one is also inhibitory. It's got like a modulating effect. So it's sort of calms your nerves. So serotonin is prevalent in patients who tend to be, or sorry, I should say, so people who suffer from depression tend to not have good serotonin levels. And so they'll use what's called a serotonin reuptake inhibitor to treat things like depression. Norepinephrine, of course, you guys have heard of that one for sure. It's linked to mood, arousal, vigilance. It's a neurotransmitter, and it's also used throughout the body for things like alpha. It's alpha effects, right? And then the most important one, the second most important one for us is the gamma aminobutyric acid, or GABA. And I'm just going to call it GABA for the rest of the day here today because it's way too hard to say that, gamma aminobutyric acid. GABA is the principal inhibitory neurotransmitter in the brain. So it's what tells most of your cells to chill out. Okay. So glutamate is the one that says, okay, let's fire, get excited. And GABA is the one that says, hey guys, calm down. GABA is like the Matthew McConaughey of your brain. All right, everybody, calm down. Okay. So the glutamate and the GABA, you can sort of relate them to insulin and glucagon. They work against each other all the time, and they're in balance, right? Hopefully they're in balance. And they sort of keep everything on a level playing field. It was really bad, Matthew McConaughey. You can say it. It's cool. GABA is the chief inhibitory neurotransmitter in the central nervous system, and it's important for benzos because benzos work with GABA. So understanding GABA helps us understand benzos. So after an inhibitory neurotransmitter sends a signal, it gets to its terminals. Those terminals are going to release GABA, and that GABA is going to make its way through the synaptic cleft to the next neuron. And when the GABA gets to the next neuron, there's actually GABA receptors on the chloride ion channels in those neurons. And so if the GABA makes its way there and attaches to those chloride ion channels, it opens them up and allows chloride to make its way into that nerve cell. Okay. So we already said that when inhibitory nerve cells, or when inhibitory neurotransmitters attach to nerve cells, and they open chloride ion channels, they hyperpolarize the cell, meaning they make it more negatively charged than it already was. Okay. So when the chloride ion channels open, free chloride, which is floating around in the sort of the interstitial space, right, intercellular space, it's going to, which is more prevalent outside the cell, is going to make its way inside the cell. Since chloride is negatively charged, it's an anion, it makes the inside of the cell more negatively charged than the outside of the cell, even more so than it was before. So keep in mind the resting membrane potential was -70. Chloride ions are going to make their way into that cell and make it even more negatively charged than that. So pick a number, usually about -85. This is called hyperpolarization. So more polarized than it was before. It's hyperpolarized. So we're going to use our critical thinking here. So knowing that a cell is hyperpolarized, what does that mean as far as its ability to reach the threshold potential? What's it going to take for that cell to reach the threshold potential? Can anybody tell me? No one wants to unmute their mic.
Would it be more sodium?
Yeah, exactly. It would need a much bigger stimulus to get it to fire. So in order to get it up to that threshold potential, we would need more sodium to pour in than what would occur in sort of a normal stimulus. Okay. So with a normal stimulus, you would get your cell to fire quite easily, but now that it's hyperpolarized, it takes a lot more of a stimulus to get up to that threshold potential and actually create an action potential. So we need a bigger stimulus. So that's how GABA works. It makes those cells even more negatively charged so that the next signal that comes from the cell that's excitatory probably won't be enough to make it fire. Okay. So that's how that works. Hyperpolarization makes the cell more difficult to depolarize. And depolarization therefore requires a larger stimulus to cause the cell to fire. So if we don't have that large stimulus, that cell won't fire. It's been inhibited by that neurotransmitter. And that's how it balances out, right? Okay, so kind of the same thing here. We have a nerve impulse coming from this axon through this terminal, presynaptic terminal here. It releases these the stores of GABA, and the GABA floats through the synapse to this postsynaptic dendrite. Now, the postsynaptic dendrite has these GABA receptors here, which are attached to chloride ion channels. And when the GABA reacts to those receptors, it allows the chloride to make its way into this cell, which eventually makes the cell hyperpolarized and harder to stimulate. And so that basically inhibits that nerve from creating an action potential, okay? Now you can see on here, a bit of a giveaway here, you can see on here that on these GABA receptors, there's actually a small spot for benzodiazepines to attach to. And they actually enhance the effects of GABA and inhibit or completely block that nerve from firing. So benzodiazepines work in a similar way to GABA, but they work with GABA. So they work by hyperpolarizing the membranes of those cells as well. So that decreases the response to stimuli and makes it takes a greater stimuli in order to make that cell fire. That can either dull or completely inhibit nerve impulses depending on the amount of benzodiazepine we use and the amount of GABA present. So obviously, the more benzo you use, the greater that effect. The less benzo you use, the lesser that effect. So low doses will cause a decrease in anxiety and will cause sedation. Mid doses will induce sleep and hypnosis or amnesia, and then high doses will induce anesthesia, so completely knock somebody right out. We tend to use low doses and mid doses in EMS, at least in Manitoba. So benzos, it's not necessarily the drug itself that's causing the inhibition. It works with GABA, so it enhances the effects of GABA, and therefore it requires that there is an amount of GABA in the brain in order for it to work. Barbiturates worked independently of GABA. So barbiturates did the exact same thing. They attach to receptors on those cells. They cause chloride ions to flow in and hyperpolarized all those cells. The thing with barbiturates is they did it independently of GABA. And so it was a lot easier to overdose patients with barbiturates than it is with benzodiazepines, because benzos rely on GABA in order to work. So if there isn't enough GABA, you're not going to get much of an effect. If there's lots of GABA present, then you get a better effect. And that's why you see some patients respond better to benzos than others do. Like I said, barbiturates are still used today. Phenobarbital is a fairly common one. Sodium pentothal is another one. Sodium pentothal is kind of a funny one. That's the truth serum. That's the one they say you give it to them and the person will tell you whatever. In veterinary medicine, my brother's a veterinarian. They still use barbiturates, specifically euthanol. They use that to euthanize animals because it's easy to do, right? So benzos are safer in that sense because they don't have unlimited effects like barbiturates do. So they increase the effectiveness of GABA by attaching to those GABA receptors and allowing GABA to do its job better, but they don't do it on their own. Okay, so if that makes sense. So we'll kind of go back up to this diagram here real quick. So the benzodiazepines will attach to these GABA receptors and enhance the effect of the GABA. So basically doubling the effect of the GABA and allowing more chloride ions to make their way into the cell. So when we do that, we hyperpolarize that cell, and we can actually block this nerve from generating a signal, okay? And it's in blocking those nerves that we actually create the effects we're looking for. So let's say this patient is having multiple seizures. It's sending signal after signal to this group of nerves. We get the benzo in there, along with whatever GABA is stored in there. We'll attach to all those cells that are firing and hyperpolarize them and make it so that the signal that is coming their way isn't strong enough now to get these cells to fire. And so that's what inhibits that seizure from occurring. Okay, does that make sense to everybody? Yeah, okay.
Jerry?
Yeah.
I'm just curious, is there potential for people to not have enough, or I guess, yeah, enough GABA receptors?
No. Well, I don't know. That's a good question. I don't know if I have a good answer for you. I think the amount of GABA receptors, I think there's probably lots of receptors. It's whether or not they have enough GABA to reach those receptors. So maybe they have, if they have some kind of disorder where they're low on inhibitory neurotransmitter, then you might see less of a reaction with the benzodiazepine. Excuse me. But whether or not you'd have people who don't have enough, I don't have a good answer for you.
Okay.
That's a tough question. Too early in the morning for tough questions. That's a good one, though. I'll see if I can find something more on that. And that was Angela, right?
Yes, it was.
Okay. I'll see if I can find you an answer, and I'll
Sure.
send it to the group. So in EMS, we tend to use benzodiazepines on a fairly regular basis. Like I said, more so now than we ever used to. We used to only use it for seizures, but now we're starting to use it for a few other things. But mainly seizure management is sort of the big one. We also use it for sedation, either procedural or chemical restraint. So in procedural sedation, we'll tend to use it for patients who maybe need to be cardioverted. It's not a very pleasant experience, so if we can sedate them first, that's really good. And what we're trying to do there is actually create amnesia. So when we're giving benzos before cardioversion, we're trying to help that patient forget that whole moment in time. Okay. So the patient will still have pain, they'll still be talking to you, they'll still feel, but the amnesic effects of the midazolam in this case is the benefit for us, because they don't remember any of it, which is sort of the advantage. It's also used, it can be used for pacing too, active pacing. So if a patient who is actively being paced and is having anxiety because of it, we could use benzo as a sedative. And then we're also using it in any patients who maybe have an advanced airway in place and they're awakening and they're at risk of destabilizing their airway. So maybe they're not quite a stable patient. We don't want to extubate them. So we'll use a benzo to sort of sedate them enough that we can keep the tube in place until we can get them to a facility. Chemical restraint, we're using benzos now for chemical restraint. Certainly it's been used in EMS in other areas for a lot longer than what we've been using it for, but chemical restraint is another good reason for benzos in EMS. And there we're talking more so about our agitated patients. Right? And then we're using it also in the treatment of alcohol or benzodiazepine withdrawal. So I'm not going to spend a ton of time going through what a seizure is and what alcohol withdrawal is and all that stuff, because really the focus is on benzos, but we'll just sort of quickly go through some of this stuff. I am going to spend a little bit of time on agitation because it is a fairly, it's not a topic we talk about a lot, so I'm going to spend a little bit of time on agitation. But I'm going to go briefly over some seizure stuff. So, of course, seizures are sudden, uncontrolled disturbances in the brain. And there are lots and lots of causes for seizures. It can cause changes in your behavior, your movements, your feelings, your level of consciousness, of course. Seizures tend to be fairly short. Most seizures don't last very long, 30 seconds to sort of 2 minutes. They can definitely go longer, and we've seen patients seize for a really long time. But the majority of seizures don't last a lot longer than 2 minutes. Benzodiazepines are used to block that nerve transmission and stop that seizure. So what we've already said, attaches those GABA receptors, causes chloride ions to go into those nerve cells, hyperpolarizes them and makes it harder for a stimulus to make that cell reach threshold potential and cause an action potential. So that's where the benzos work in seizures. Alcohol and benzo withdrawal is usually caused by an abrupt cessation of intake. So for whatever reason, the patient just stops cold turkey, or they're hospitalized and now they don't have access to it, or whatever. But it's that sudden cessation or abrupt cessation of intake of either the alcohol or the benzo or whatever that causes sudden onset of withdrawal symptoms. Can include things like insomnia, tremors, anorexia, nausea, headaches, diaphoresis, palpitations, and it can get to even worse things like hallucinations, seizures, delirium tremens, that sort of stuff. So benzodiazepines are used in those scenarios to control that psychomotor agitation and prevent progression to more severe withdrawal, prevent seizure, that sort of thing. They'll use them sort of short term. I know they'll be prescribed to patients. They'll use them short term until some of this stuff dissipates, and then they'll put them into programs to help them get through the withdrawal. Agitation is an unpleasant state of extreme arousal. That's the definition that was found for this. Agitation can be a lot of things. Very scary calls. Mostly because of the risk of violence. And I think that's the thing that we have to sort of keep in the back of our minds, that this can go south very quickly. So we need to sort of be hyper vigilant to the fact that the patient could become violent. An agitated patient can feel stirred up, excited, tense, confused, or irritable. And things like even confusion can lead to a lot of agitation in a patient. I think back, I don't know if a lot of you remember that incident at the airport in BC a number of years ago, where there was a gentleman who, if I remember correctly, he didn't speak English and was being asked to, exit this room or whatever. So he was really confused and he got irritated, and eventually he started getting to a state of agitation or excited delirium. So even things like confusion can lead to an agitated state. Causes of agitation. I should actually be asking you guys this. I am going to ask you guys this. I'm going to open this up to you guys now. So can anybody give me some causes of agitation? Don't be shy.
Dementia or Alzheimer's?
Yeah, dementia and Alzheimer's for sure. Absolutely. What's another one?
Intoxication.
Intoxication, yeah. So drugs or alcohol, right? Could be one or the other. That's a good one. What else?
Head injury?
Head injury, yeah.
Low blood sugar.
Low blood sugar, good answer.
Stroke.
Stroke, yeah.
Just in some of the comments here too, Jerry, I don't know if you can see these or not. We have a bunch of people who are writing answers too. So anxiety, meth, drugs, being awakened from an overdose, postictal stage of a seizure, as well as mental health.
Awesome. Good answers. Yeah, sorry, I'm not looking at the chat here yet. I'll take a look at it towards the end and answer any questions that are in the chat. It's too much for me to watch. I got a very small brain. I can't watch all these screens at once. But yeah, so here's a few, and you guys have named some others too. Alcohol withdrawal for sure. Allergic reactions, caffeine intoxication. So the people who are drinking Red Bulls and popping caffeine pills. Liver or kidney diseases, intoxication, hospitalization. That could be more so for your dementia patients, so the confusion and that sort of thing. Hyperthyroidism, infections, nicotine withdrawal, poisoning, drugs like steroids and theophyllenes and that sort of thing. Trauma for sure, traumatic brain injuries. Could also be things like a brain tumor or an aneurysm that's putting pressure in the brain. Vitamin B6 deficiency, which I don't quite 100% understand that one. I have to do some research on that. And then, of course, mental health disorders, things like schizophrenia, paranoid schizophrenia, that sort of thing. So lots of causes of agitation, and the sort of things that we need to sort of think about when we're running across this patient who's agitated. Is this somebody who has a mental health disorder who I'm not going to be able to talk down? Is this somebody who's going through an alcohol withdrawal, right, and is chemically dependent? I'm not going to be able to talk this person down. Or is this somebody who's just confused, you know, a little bit panicked, doesn't know what's going on? Maybe a little bit of a discussion with them and talking to them will get them calmed down to the point where they're going to cooperate with me. Or even calm them down to the point where they'll cooperate with taking an oral medication like Lorazepam, or in the case of like a olanzapine, right? So these are all things you sort of want to keep in the back of your mind when you're running across an agitated patient. So benzos are used in the treatment of agitation because of their sedative effects. So sort of that mid-dosing that we talked about before, creating that sedative effect. Now, what you'll find is the more agitated somebody is, the more benzo is required to actually create that effect. The more relaxed they are or cooperative they are, the less it takes to create that effect, right? So if you have a whole bunch of excitatory neurotransmitters firing all over the place, it's going to take a little more work for GABA and benzos, excuse me, to take care of the agitation. Okay, so we're going to talk about a couple of specific benzos, mainly because they're the ones that we're carrying in EMS. There are lots of others, and there's lots of good reasons for using other benzodiazepines. But we're gonna stick to talking about these two because they're the ones that we should be the most familiar with. So Midazolam is a really great drug because it has a really rapid onset of action. It works really, really fast compared to other benzodiazepines, but it also has a short duration of action, which has goods and bads. So it works really fast, which is great, but it doesn't last as long as other benzos, which depending on your application could be good or bad. If you're wanting something more long-term, like treating alcohol withdrawal or treating someone with agitation, not the greatest drug because although it does work fast, it doesn't last very long and you have to repeat dose. But for things like procedural sedation for short procedures like a cardioversion, it's wonderful because in about 20 minutes or so, the patient's going to start to remember things again. Okay, so really great for that sort of thing. So it's short acting, or it has a short onset of action, but it's also short acting. Lorazepam would be classified as intermediate acting. Takes a little longer for its effects, but it also lasts a lot longer. And depending on which book you're reading, or I think UpToDate has its duration of action between 10 and 20 hours. So lasts a really long time versus the duration of action of Midazolam, which is about 2 hours. But its peak effect is way shorter than that, right? And both of them would be shorter, but the actual duration of action is quite a bit longer. So Lorazepam is good for things like where you're wanting a longer duration of action. So sedation for somebody who's agitated, or sedation for a patient who's going through a benzo withdrawal, something you want to last longer. So yeah, it really just depends on what it is we're trying to do. The care maps kind of spell out which one we're going to be using, but that's the reasoning behind those care maps and why those benzos are where they are, because of their onset and their duration of action. Midazolam, of course, is a little more versatile for us. It can be delivered IV or IO. It can be delivered IM, and it can be delivered intranasally. And of course, I have a little star beside it there because with the COVID pandemic, and I promised I wouldn't say the word, but I said it, COVID. We can't give intranasal medications right now. But certainly IV and IM, we can still give Midazolam. Lorazepam is a tablet, or will be carried as a tablet, and it can only be given orally. Okay. So even there, kind of tells you the applications of it. Lorazepam being an oral drug, it's going to be longer before it reaches its effects, or before it reaches its effects. Midazolam, a lot shorter because it's being given IM or IV. You're going to get your effects a lot faster. So the onset of action of midazolam, you're looking at about 15 minutes if you're giving it intramuscularly. So just so you sort of know what to expect, if I have a patient who's agitated and the only route I have is intramuscular for midazolam, it's going to take about 15 minutes before we start to see effects. And the peak effect of that, so where it's going to work its best, is going to be around 30 to 60 minutes. So it's going to take some time for that midazolam to really kick in. So keep that in mind when you give the midazolam. If you're giving it intramuscularly, don't just assume it's going to start working right away, and don't give it and then say, oh, this didn't work. Let's give it more. Give it some time. It's going to take a little bit of time. IV or IO, about 1 to 5 minutes. So it doesn't take terribly long. The average is probably about 3 minutes before it starts to take effect. And you'll certainly see that when you're giving it for cardioversion, for example. So I've heard horror stories of it being given and then, the doctor pressing shock and the patient remembering it all and then forgetting the 20 minutes after that because they didn't give the midazolam enough time to kick in. So just make sure when you're giving it, give it, a couple minutes, reassess them after, 2 minutes or so, start asking questions and see if the midazolam is taking effect. This one elderly woman I gave midazolam to once was more than happy to tell me about some very intimate things about her at that time deceased husband. So I knew the midazolam was working because I don't think she would have told me those things without the midazolam on board. So it was pretty easy to tell when it was working. Another woman told me how attractive I was, so I was pretty sure that the midazolam was working because if she could see me clearly, she would know that it was obviously the benzo talking. So you can usually tell when it's taken effect, and that's the time to do the cardioversion or whatever it is you're going to be doing. I guess cardioversion. Intranasally takes about 5 minutes, 10 minutes to reach peak effect. So yeah, it takes a little bit longer, but super effective way of giving midazolam. Again, we can't do it right now, but a good way of giving midazolam. Lorazepam given orally has an onset of action of about 20 to 30 minutes. Of course, anything taken orally is going to take a lot longer. The nice thing about Lorazepam is it has a really good bioavailability when given orally, meaning a lot of it is available to be absorbed and used as pure drug. So I think like most textbooks will say 85 to 90% of the drug is available when it's taken orally. So that's pretty good. So Lorazepam is a really good oral benzo compared to other benzos which aren't quite as available and you need to take more of. So Lorazepam is actually a fairly potent benzo. And so it's a really good one to give orally because it works really well. If you were to compare midazolam to lorazepam 1 for 1, so meaning the IV version of both, lorazepam is about 2 times as potent as midazolam. It's a very strong benzo. So you would give half of the dose of lorazepam you would give for midazolam if you were giving it IV, but again, we're only carrying it orally. The disadvantage to lorazepam is the IV version has to be refrigerated, so it doesn't really work well for us. Okay, so understanding the onset of action, how fast it works, how long it lasts, understanding how we can give the drug helps us understand why we're giving that specific medication for the condition we're trying to treat. So it's important you kind of have an understanding of that. Another good thing to have an understanding of is how to administer these, what the concentrations are. So lorazepam, I just as a disclaimer for those of you who aren't from the southern region, we're not carrying it just yet in southern. We have to get it back onto the trucks. I imagine we're probably looking at a 1 milligram tab. And if you guys from the other regions are carrying it, you can let me know what you guys are carrying. But I think 1 milligram tabs is kind of the way to go. Midazolam, we're carrying ampules or vials of 10 milligrams in 2 ml. So it's the 5 in 1. And when you're giving midazolam intramuscularly, you want to give it full concentration. So you're not going to dilute that. Same thing if you're giving it intranasally, you're going to give the full concentration of whatever dose it is you're wanting to give. When you're giving it IV or IO, it's actually best, it's recommended best practice is to dilute it in a 1-to-1 concentration. So given that it's 10 milligrams in a 2 ml vial, you would drop those 2 milligrams in a 10 cc syringe and dilute that with 8 cc's of saline. So you have a 1-to-1 solution. And they recommend injecting your dose over about a 2-minute period. So you don't want to slam it in there. You want to give it about a 2-minute push, so a slow push to get it in there. So if you're giving 5 milligrams, you're going to push that over sort of a 2-minute period. The nice thing about diluting it IV too is it's you're a lot less likely to overdose because it's easier to push, you know, a 2.5 mLs of a solution versus pushing, you know, a 0.4 ml sort of thing. So it's kind of nice in that sense that you can draw it up and dilute it, and a little bit safer to give it that way, especially when you're giving it IV because it obviously has a much faster onset of action. You don't want to overdose. So things that interact with benzodiazepines, the big ones are anything that are CNS depressants. So alcohol, tranquilizers, opioids, barbiturates, anything that depresses your CNS system is gonna that benzo is just gonna perpetuate that. So you're gonna have your patients, you know, respiratory depression and you know, bradycardias and that sort of thing. So we really want to make sure we're monitoring those patients. If we have no option but to give the benzo to a patient who you know, has been using alcohol all evening and is having a seizure, we're just going to have to monitor them more closely and be aware of the fact that patients who are already on CNS depressants are going to, you know, have the potential to interact with that benzo. A couple of warnings with benzos. Sometimes it's fairly rare, but sometimes benzos can cause anterograde amnesia, meaning people have a hard time creating memories after receiving the benzos. That's more so for the patients who are on benzos more long term, not so much for our short term use that we're using for EMS. But you know, it's rare, but it's possible. It can cause cardiorespiratory effects. Of course, we just talked about respiratory depression, and it can cause hypotension and that sort of thing. It can also cause CNS depression. Obviously, it's a sedative, a hypnotic, an amnesic, and so and it works with Gaba to inhibit nerve cells. So it's going to cause some CNS depression. So with that in mind, you want to make sure you have your patient on a monitor, that you're monitoring SpO2, you're monitoring their blood pressure, you're monitoring their ECG and their LOC while you're giving benzos. It can cause hypotension, of course. And then it can have paradoxical reactions. You can actually have patients who do the opposite of what you're expecting. So when we give a benzo, we normally expect sedation, sort of a calming effect, or amnesic effect, hypnotic effects. You can get some patients who have paradoxical reactions, so they actually become hyper and more alert, more vigilant, that sort of thing. Tends to happen. You'll see it with kids, and then patients on specific medications. But it's again, it's a fairly rare thing. So when we're monitoring patients, one of the things we want to make sure we do is we want to monitor their level of sedation. How much have we sedated this person? Are we over sedating them? Are we sedating them just enough? Are we not sedating them enough? So that could determine if you're going to do a repeat dose of something or whatever. Also kind of not listed on here, but the level of relief for the seizure. So if I've given them a dose of midazolam and they're still seizing, was the dose not enough? Do I need to repeat it, etc.? You want to monitor their respiratory rate again, because they're going to cause CNS depression. And you especially want to monitor that respiratory rate in patients who are at risk for respiratory depression already. So patients with COPD, patients with bronchitis, chronic alcoholics, people who take barbiturates or tranquilizers, those patients, you really want to monitor their respiratory rate quite a bit. CHF patients too is another good one to make sure you're monitoring closely. Heart rate, again, we can cause bradycardias. Blood pressure, we can cause hypotension, so we want to be monitoring those fairly regularly. If you're using the new X series, which I think most of us are now, the nice thing about the blood pressure, go into the BP, switch it to automatic mode, and set it to like 5 minutes, and just get it to automatically take a blood pressure for you every 5 minutes if that's available to you. And then, of course, their oxygen saturation. Anytime we give something that's a CNS depressant, we want to make sure we monitor their oxygen saturation. Not even a bad idea to put them on some low levels of oxygen if you think it's required. And then you just monitor that oxygen level as much as you can. So those are all good things to make sure you have in place. This is something we had in, well, we still have in Southern. I don't know how much the staff are using it, but it's really just a checklist. It's not something they need to fill out, but it's just a checklist of things they should have in place before they do sedation or give a benzo, that sort of thing. So equipment at the bedside here, they want to make sure the patient's pre-oxygenated. So this is more so for sedation than seizure management. I should preempt that. If they have pulse oximetry, cardiac monitor in place, have a supraglottic airway handy if they need it, ventilation rescue equipment, so BVM, oxygen hooked up to it, OPAs, NPAs, that sort of thing. Their suction should be functional and ready. And if they're using fentanyl, for example, along with it, then a reversal agent like naloxone should be handy as well. And then there's a pre-sedation assessment. So just questions they should ask. Do they consent to the treatment and sedation? So let's say we're about to do a cardioversion and we want to sedate the patient first. Are they consenting to the treatment? Are they consenting to sedation before the treatment? Do we have IV access? Is it patent? Have we reviewed their past medical history? Any allergies? Their patient weight? Do we know their weight so that we can assess them for correct dosing? Do we know if they have a difficult airway predictor, right? So before I give somebody something that's going to sedate them, make them hard, or maybe stop their breathing, do I know if I'm going to have an easy time getting an eye gel into them, right? Most of the time you do, but you get the odd patient who isn't. So in the middle here, we have this difficult airway assessment. So for a supraglottic device, we look at restrictions, obstructions, or obesity, distorted anatomy, short thyromental distance, so less than 3 finger widths from the tip of the chin to the thyroid. So if you don't have at least that much, it's going to be a little harder to intubate those patients, right? Do the sedation benefits outweigh the risks is a great question, right? If I'm going to waste too much time trying to sedate my patient and they're in this SVT and their blood pressure isn't very good, am I helping them by sedating them first, or is their condition just going to get worse by the time I get the sedation done? So maybe we'll just skip the sedation. Right? What if my SVT patient is actually pregnant? Is there a benefit to giving this midazolam, or am I going to hurt the baby? Most physicians will tell you you're probably going to hurt the baby, so skip the midazolam and just cardiovert, right? You might want to call OLMS before you decide that one, right? So just things to keep in mind. So the checklist is kind of nice to just kind of follow and go through quick. Do I have all this in place? Yeah, I do. And again, they don't have to fill these out. The checklist is just there, and they can look at it and say, okay, yeah, I've got everything I need. Let's do this.
I just got a question on that, Jerry.
Yeah.
I've had this conversation with one of our docs down here, and he says, you guys shouldn't be doing that. Conscious or doing the sedation procedure. Do we have to contact OLMS to do that, or we can just do it on our own as an ICP?
So I'm, we can look at it, but I'm pretty sure it's still in our care map under the unstable tachycardia. We can pull it up later if you want to and take a look at it. Has anybody got it handy right away? If it's in our care map, we can do it.
All right. No, it's just a conversation we've had down in the emergency room, and
yeah,
it's just I just didn't know if anybody else was getting those conversations with their doctors.
Anybody else on the line getting physicians telling us we shouldn't be using midazolam for sedation before cardioversion? It's pretty standard. You see it in hospitals all the time, so it's pretty standard. But okay, antidote. We get this question every once in a while. Do benzos have an antidote? And they do. Benzodiazepines do have an antagonist, and it's called Flumazonel. Flumazonel competes for the same receptors that benzos do, but it has a different effect. So it's an antagonist, meaning it blocks those receptors, or when it attaches to it, it either has no effect other than blocking the other drug, or its agonist, or it has opposite effects to what we expect. In this case, when Flumazonel attaches to the benzo receptors, it basically just blocks them, so the benzos have no effect anymore. It's used with caution. It's pretty controversial. Even if you look at sort of the up-to-date site and you look at Flumazonel, it's still one of those, and should we use it, should we not use it? So the problem with Flumazonel is if you use it on patients, especially patients who are chronic benzo users, you can actually induce a sudden seizure. And then what are you going to treat them with? Because you just blocked all their benzo receptors, right? So definitely used in caution in EMS. There are places that do carry it. It's kind of a scary one to give because you can induce a seizure and then you're kind of you don't have much in your bag of tricks to stop a seizure after that. So. Okay. You can induce, like I said, withdrawal symptoms with Flumazonel. Certainly, symptoms of benzo withdrawal would be things like anxiety, depression, panic attacks, psychotic reactions, sleep disturbances, irritability, increased tension, tremors in the hands, sweating, difficulty concentrating, retching, nausea, weight loss, heart palpitations, headache, muscular pain, and of course the bad one would be seizures, and you could induce the VTACs and BFibs and that sort of thing too. So if you're treating a patient who's going through a benzo withdrawal, these are the things you might see. If you're seeing a patient who's just been given Flumazonel, these are some of the things you might see as well if they're a chronic user of benzos. So just sort of something to keep in mind. There is an antidote, but it has its place, and it's not always, it's a little bit controversial as to when to use it. Okay, one of the last things I want to talk about specific to benzos is just sort of the documentation requirements. So anytime we're using a benzo, we want to make sure we've described the patient's signs and symptoms and all their vital signs and their LOC, the indications for why you used the benzodiazepine, and the dose and time for each. Here it says specifically midazolam, but any benzo, dose and time for the drug that you used, the resulting clinical effects, and then of course your repeat assessments and vital signs should be documented. Any changes from baseline and anything that happens along treatment or transport. When we're using a benzo, of course, we have to mark down the discard if there was any. And of course, a signature and license number of the medic who used it, and a second signature is required from a crew member witnessing the discard of that midazolam. So you want to make sure that you're both signing that PCR and you're both witnessing the discard. Okay. So I have 3 really quick case studies. I realize we're already at 1 hour and 37 minutes, so we're kind of getting close to the end time of this session here. So we'll quickly go through some of these case studies. I have one seizure case study. I have one for alcohol withdrawal, and I have one for agitation. I'd like to go through the seizure one for sure and the agitation one, and if we have time, we'll talk about the alcohol withdrawal case study. But I want to spend some more time on the first 2. So this is going to be interactive. So I want you guys to sort of tell me the things that you would be looking for, or what your differential diagnosis might be, and then certainly what you would want to do for treatment. Okay. So these aren't timed. They're not real time scenarios. So take your time to answer the questions. So we have a 79-year-old woman who has she's had 2 generalized seizures, and they're tonic-clonic. These are new for her. She's never had them before, and her family witnessed them and called 911. Okay. So you arrive on scene, and you form a general impression as you're approaching her. You notice she is unresponsive. She's not responding to her daughter, who's sitting by her side. Her breathing seems regular but slow and shallow. She looks pale, and she was obviously incontinent of urine, and she has some minor bleeding from the mouth. So the assumption is that she maybe bit her tongue or hit her face on the floor or something like that. Okay. So just from that general impression, what are people thinking they'd like for a workup? What do you want your partner to do for you while you're
correct airway
getting questions answered? Correct airway, yeah, for sure. We want to get on that right away. So make sure that we have her in a position to protect her airway.
suction.
What else would we like done here?
Blood sugar.
Suction, yeah. So yeah, especially you want to take a look inside her mouth and make sure there isn't some active bleeding going on that needs to be suctioned. We want to protect that airway at all costs. So we'll get some suction going. I heard blood sugar. Did I hear that right?
Yeah.
Rapid trauma assessment.
Good. So rapid trauma assessment. Good. So we're going to do a quick head to toe. So we'll get our partner doing that while we're asking questions. So my partner is going to take care of ABCs, suction that airway if required, put in an OPA if required, whatever. So they'll protect the airway. Quick head to toe, quick trauma assessment, looking for any obvious injuries or anything that could be detrimental to our patient. Then we're going to get them to get a set of vitals. So somebody was saying blood sugar. What other vital signs are we interested in? None. Don't care about the rest. What other vitals do we want?
Your
O2
blood pressure?
saturation.
O2 sats, blood pressure,
Yeah. Blood pressure. What was the other one I heard?
level of consciousness,
O2
pupils,
sats. Yeah. Blood pressure.
Pupils?
temperature.
Good. Temperature. Good. Awesome. Okay, so I'll give you guys a quick set of vitals here. You can jot them down or you can just ask me again. Your patient has a blood pressure of 92 on 56, has an O2 sat of 90% on room air. She has a pulse of 68 and it's regular. Respiratory rate of 12 and regular, a little bit shallow. Has a temp of 37.3 and a blood sugar of 5.6 millimoles per liter. Okay, anything there jumping out at anybody?
Does she have a 3 lead? What's her rhythm?
She's in a sinus. Yeah, just a sinus rhythm.
Blood
You do
pressure
see the
is a
occasional
little on the low
PVC, though.
side.
Yeah, BP's a little low.
Is she a smaller
O2
woman? Like how does
saturation.
Yeah, good question. So yeah, she's probably about 150 pounds. So fairly average. She's about 5'7", 5'8". Her daughter says she's usually fairly active, takes a walk twice a day, every day, fairly consistently. Yeah, so not a smaller lady. So maybe that blood pressure is a little bit low. I agree.
I don't know if anybody's asked us, what's your GCS?
Yeah, she's unresponsive. Okay,
Like to know-
so we have this. Oh, sorry, go ahead.
Know what medication she may be on.
Okay, we'll start asking some questions. Okay, so while your partner's doing all that, you're asking questions. So she has a past medical history of asthma. She's a non-insulin dependent diabetic. She has a history of gastroesophageal reflux disease, hypercholesterolemia, hypertension, and osteoporosis. And her doctor recommended she exercise every day, just moderate exercise, taking walks to help with the hypertension and the hypercholesterolemia. And she takes medications for all of her other conditions. Her meds, aspirin, clopidogrel, salbutamol, Combivent, ranitidine, and valsartan. And she's not allergic to anything, according to her daughter.
What's
Okay.
her end title?
End title is 38.
Did the family she's with, did they notice anything different? Like, did she take anything different? Maybe she took a medication like more than she usually would or less than she usually would that would have caused the seizure?
Yeah, good question. No, she's on pill packs, and they check the pill pack. Everything looks normal. And as far as the puffers, they can't really tell, but the pill packs look good. So
I would try to start an IV and then load and go, and then drop medication for Midaz if she has another grand mal.
Yeah, so kind of preemptively just preparing yourself kind of thing. Okay. So what else would you include in your assessment? What could be the cause of this patient's seizures? What are some things that could be causing this?
A seizure secondary to a fall or head trauma.
Sure, could be head trauma, traumatic brain injury of some sort.
Undiagnosed brain tumor.
Yeah, could be brain tumor for sure.
I have an infection.
Yeah. Yeah, and you'll see patients with like UTIs that'll have seizures and weird altered LOCs, and yeah, so infection for sure. What else?
What are her
Stroke,
pupil size?
Yeah. Her pupils are equal and reactive. They're both about 3 millimeters.
She could have become extremely hypotensive, passed out, got a head injury, and then seized.
It could be all of that, you bet.
Alcohol withdrawal.
Could be alcohol withdrawal, absolutely. Anything else?
Do we know if she had any stroke-like symptoms?
Her daughter doesn't think so. She was talking to her just before the seizure. She didn't notice anything.
Had a question pop up here too. Is she dehydrated in any way?
Oh, that could be, right? So we can check skin turgor, and we can look at, mucous membranes. Does her mouth look dried or her eyes look dry? That sort of thing. Yeah. Good questions.
Are there track marks?
Track marks, yeah. Maybe grandma likes her crystal. Grandma likes
long
to
was
chase the
the
dragon once in a while.
Maybe.
The seizure lasted about 45 seconds.
And there was a break in between both of them?
Yeah, there was a break of about a minute and a half.
Has she overdosed on her medication? Check her pill pack, or
doesn't seem like. Seems like her pill pack looks good. Okay, I think we'll stop it. Those are really good questions. So if you, I don't know, most of you probably heard this before, but that AE/IOU tips that you kind of use for anybody who's got an altered level of consciousness works really good for seizures. So alcoholism, epilepsy, infection, et cetera, et cetera. So good questions to kind of, if you need to organize in your head, to kind of go through what are some of the things that we can sort of try to rule out. In this case, we really can't rule out. We don't know what's going on here. Okay. So can we treat the cause? At this point, we don't know what the cause is. Okay. Now, while you're getting her onto your stretcher, you've got your IV in place, you've got oxygen going. She starts to have another seizure right in front of you, and it doesn't seem to be stopping. So what are your next steps? What do you guys want to do for her?
protect her airway.
Protect her airway. Okay.
And you want to
Consider Midazolam.
figure out how much she weighs so you can drop.
Yeah. So we asked earlier, she's about 150 pounds because nobody knows kgs.
That's like, that'd be like 68 kilograms?
Yeah, something like that. I would say 70, just make the math easy on you. So we're trying to decide if we're going to give Midazolam. We've got an IV in place, right? And so if your patient is 6 months or older, we're going to give 0.05 to 0.1 milligrams per kilogram to a max of 5. So if she weighs 70 kilograms, do we reach the max dose here?
Yeah.
Yes.
For sure. So anybody 50 kgs and up is going to get that max dose of 5, right? Again, it's a range, so you don't necessarily have to use it, but in this case, she's had a couple of seizures. She's had another one here. Probably just going to give her the max dose of 5 milligrams. And again, like I said earlier, you want to infuse it slowly over 2 minutes. So draw this up in a 10 cc syringe, dilute it 1:1, and you're going to push this over about 2 minutes. Really hard to push 1 cc over 2 minute period time. So dilute it in the 10 cc syringe. So it's a 1:1 solution, and you can push 5 cc's of that over 2 minutes. Okay. And then, of course, repeat it every 5 to 10 minutes as required, if required. Okay. All right. So, let's see here. That's if we're giving it IV. If we were giving it intramuscularly, it would be 0.2 milligrams per kilogram. Here we can't dilute it. We have to give it in its full concentration of 5 milligrams per ml. Your max single dose is 10 milligrams. So 0.2 milligrams per kilogram, your 50 kg patient is going to get the 10 milligrams. Okay. And this patient was 70 kg, so you can go ahead with the 10 milligrams. And you would repeat that one once in 10 minutes if required. Okay. So we give her the midazolam. We'll go back to the presentation. We give her the midazolam and the seizure stops. But the patient doesn't regain consciousness. You repeat vitals and they all stay about the same. And we transport her to the hospital. Okay, so we're going to transport to the closest facility, of course. How would we transport her? So we've got her in a semi-Fowler position. We've got her on oxygen, all that stuff. That's not what I mean. But your transport code, is this emergency, non-emerge? What do you guys think? This is always a big topic of discussion.
Emerge.
Yeah,
Emerge?
I feel like your vitals haven't changed much. It would be emerge.
She's not responding well either. So
Yeah, exactly. Yeah, this is definitely not a green patient or a Gramber patient. This is definitely somebody who needs to be seen right away. So yeah, awesome. Okay, that was a really simple one, I realize. I'm not going to spend too much time on seizures. I think we study them quite a bit, but I wanted to go through it really quickly and just sort of get your thought process and differential diagnosis and stuff. So that was really good. You guys did a fantastic job on that. Let's do this one here, and then we'll see how long this one takes. This is a 24-year-old male who's screaming at passing cars, and he's bleeding from the chest. Police are en route, and they arrive on scene basically the same time as you guys. And it's a passerby that called 911. So what's the first thing you're thinking of when you hear 24-year-old male screaming at passing cars?
A mental health crisis.
Mental health crisis. Yeah, mental health crisis of some sort, maybe drugs. Yeah, some kind of agitation, right? Perfect. You arrive on scene. He is standing outside. He's shirtless. It's about 12 degrees outside, kind of an early spring day. He is conscious. He appears anxious and agitated. You can see just in the passenger seat of the truck, you can see that. He's pacing. His fists are clenched. He's screaming at cars that are passing by. He's screaming at your ambulance. He's screaming at the police. You notice a laceration to his chest with minor bleeding. And he's got a piece of broken glass in his hand. His airway appears patent. He's screaming out loud. He doesn't seem to be having any trouble moving any air. You can tell his breathing is fast. It's quite rapid. And he's screaming at cars and police and drivers, and he's screaming at you. And now this part is important. It's not the fact that your patient is screaming, but sometimes what your patient is screaming that can give you a lot of clues as to what is going on. So if my patient is screaming something like, "Where's my family? Where's my family? I'm lost. I don't know what's going on. Where's my family?" That's somebody who's maybe confused. It could be a dementia patient. Could just be somebody who's lost. It could be like a young child who's lost. It could be somebody who's, maybe lost their family recently. They all died, and they're just coming to that realization. That's probably somebody that we can talk down a little bit and get some cooperation from. Now, if my patient is yelling, "The government is trying to control me, and they put a chip in my chest to find my location, and you guys are all part of the government conspiracy," then I know that this is probably somebody I'm going to have a really hard time talking down, but we're going to try anyways, okay? So past medical history on this guy is unknown, but the police tell you that they've dealt with this gentleman before, and they transported him to the hospital last time they dealt with him, and subsequently they ended up taking him to a mental health facility. So what does that tell you?
He's got a history of mental health issues.
He's probably got a history of mental health issue. Exactly. So is this going to be somebody you're going to have an easy time talking down and getting them to cooperate? Maybe, but there's a likelihood that maybe not. He's also cut himself, so there's some potential for violence here. He's obviously not feeling too much pain, and so those patients can be a little scary as well. Okay. Now, one of the things with agitation is identifying potentially violent patients. That's probably the most important thing for us. It's always scene safety. So when I'm talking about scene safety and identifying potential violence, what are some of the things we're looking for on a scene?
Potential for like weapons or anything like?
Yeah, potential for weapons for sure. So knives, kitchen knives, broken glass, firearms, of course, baseball bats, hockey sticks, kids' toys, anything could be a potential weapon, right? So just keeping that sort of stuff in mind. What are other things we're looking for when we're trying to maintain scene safety?
The patient's disposition, like
Your exit strategy.
Yeah.
Okay, yeah. So I heard, so someone said patient's disposition first. Go with that one. So you tell me more about that.
Body language of your patient.
Sorry, keep going though. First, whoever gave me the first answer there.
Sure, yeah. If they seem tense or wound up, if they're pacing, how they're speaking to you, like their volume, pace, tone.
Exactly. So are they pacing around? Are their fists clenched, right? Are they super French like me and talking with their hands like this? Or are they sitting down in a chair and telling you that they're not happy today and they could really use some help, right? So their disposition tells you a whole lot. And this guy is pacing around. He's already cut open his chest trying to find this microchip, and he's screaming at cars that are passing by. So we know he's quite agitated, and there's a lot of potential for harm to happen to him and to us. So we need to keep that in mind. Someone said exit strategy. Tell me more about that. What are you thinking about that?
I think it's important to find an exit strategy in case things go south, and scene safety for you and your partner is a big deal. So
yeah, exactly. So never putting yourself or never putting the patient between you and the exit, right? Always making sure you've got your back to the exit, so if something happens, you can get out of there, right? And all of this that we've put together is called situational awareness. So when you arrive on a scene, it has to start right away as you're approaching the home, as you're approaching the scene, wherever the scene is, constantly looking for those things that could be hazards and looking for ways out of those. Walking to somebody's house and you go out on a farm and you walk onto into the entranceway and there's a gun cabinet and it's open, right? The hair on the back of your neck should be standing already. Okay. It's in a kitchen. There's lots of sharp knives, right? It's that person's home. They know their way around better than you do, right? So you always want to kind of approach with a little bit of caution. And another really important thing is don't do this alone. Make sure you have the police. So if this guy here, we definitely wouldn't approach unless the police were also on scene to help us out. Okay. So making sure that scene safety is always top of mind. Safety for yourself, then safety for your partner, and then safety for everybody else. Sort of some of the things that are sort of associated a little bit higher with violence are, of course, male gender, a history of violence. So ask the police when you dealt with this guy last time, did he get violent? If they're like, oh yeah, for sure, he fought us tooth and nail, keep that in the back of your mind that this could happen again. Drug and alcohol use, those are all things that are sort of tied together with violence. Patients with a history of violent behavior are more likely to be violent again. So keep that in mind. So again, ask the family, ask their caretaker, ask the police, whoever's on scene, if they've dealt with this person or if they know this person, is this somebody who's been violent before, right? So always do that risk assessment and that attention to safety. So we talked about the patient's disposition. So some of the things you're looking for are like provocative behavior, angry demeanor, right? Screaming, yelling. This guy's screaming at cars that are going by. Loud, aggressive speech. So if they're really yelling and they're saying aggressive things, that tells you they're sort of heading in that direction. Tense posturing. So like if they're really gripping their arms tightly, they're clenching their fists. Their whole body seems tense and they're, sort of shaking and vibrating. If they're like pacing or frequently changing body positions, so they're sitting, they're standing, they're sitting, they're standing, they're pacing, right? So that tells you they're getting more and more agitated as this goes on. And then, of course, aggressive acts like throwing objects or, pounding walls or hitting themselves or throwing things at you, that sort of thing. If you read psychiatric texts on agitation, they spend a lot of time talking about the patient's hands, and the more active their patient's hands are, the more tension in their hands, the more likely you're going to see, an attempt at some kind of violence. So really pay attention to their hands a lot. What are their hands doing? Are they really clenched? Are they super overactive? So just something interesting. Okay, so we've got this guy who's obviously very agitated. He's screaming at us. He's screaming at police. What's sort of the first thing you want to try with this gentleman? So the police are on scene with you, right? What's some of the first things you kind of want to try to sort of settle this person down?
Try and develop a rapport with them and try and calm down.
Yeah, absolutely. So you would kind of do a sort of like a verbal de-escalation, right? So you're wanting to talk to this person, see if you can calm them down. The other thing with talking to them, the more you can talk to them, the more you can kind of assess what the problem might be or what's causing this, or what kind of state they're in right now, okay? So it can help you determine your treatment as well. So patients who are agitated but are cooperative, they might be more apt to be de-escalated with verbal versus patients who are like actively violent, right? So you might be able to talk them down or even convince them that it's a good idea that maybe they take some Lorazepam, right, and sort of calm their nerves. Those patients who are agitated but cooperative are more likely to do that for you. But if they're not cooperative, they're less likely to ever be at that point. So something to kind of keep in the back of your mind. These patients all deserve a chance to calm down. So we need to give them that. So we're never going to race into the scene, jump on this patient, restrain them, shoot them up full of drugs, and then back off and hopefully he chills out. We want to give them the chance, try that verbal de-escalation first in all these patients, and then sort of assess the need for an escalation of, restraint and chemical restraint, etc. Right? It's going to become pretty clear to you fairly quickly if that's the route you got to take. Some patients you'll find will become angry because they feel like they're not being taken seriously. So one of the worst mistakes you could make is to have a smile on your face or giggle at something that the patient maybe says that you find is humorous, right? If they feel like they're not being taken seriously, that can escalate their emotion even more. So we want to make sure you're really keeping your emotions in check as well and just keeping a calm demeanor. Also the way you speak, so that calm, soothing voice, similar to what we're doing now, everybody just sort of talking, very relaxed, versus the sir, please stand down and really forcefully speaking to them. You're going to find they're going to be less receptive to that. Any of you who have kids, you know that when you yell at your kids, they don't listen to you, but when you sit down and you calmly explain to them why you said no about something, they tend to receive that a little bit better, right? So same thing applies here. That sort of calm demeanor is going to be received better than sort of that aggressive. Some patients who are agitated are actually aware of their control problems, and they might actually welcome you guys helping them out. They realize, okay, I know this isn't right. I shouldn't be acting like this. And so if you can sort of, again, present yourself with that sort of calm demeanor, they're going to be more likely to want to seek your help than if you're, showing up and you're scared or agitated or whatever. Another tip is addressing things directly. One of the things we're sort of afraid to do, especially if you're afraid of confrontation, one of the things that we're afraid to do is we're afraid to address violence directly. So a really good thing to sort of get into the habit of is to directly ask them, do you feel like hurting yourself or hurting someone else? Now, in this case, a little bit obvious, he's wanting to hurt himself because he's already cut this, chip out of his chest. But do you feel like hurting yourself, or do you want to hurt somebody else? Ask the question. Let them explain it to you, right? Are you carrying any weapons? Ask them, right? State sort of really obvious things like, you look angry. Tell me why, and let them associate the words with their feelings. So if you say, you look angry, it gets them to sort of reset and go, yeah, I am angry. Here's why. And they'll start to explain it to you. And a lot of times that conversation can sort of help mitigate that agitation and sort of calm things down, right? If you see somebody is really struggling to sort of control their agitation, then you can say that, you obviously have a lot of willpower, right? To control. We can help you if you're struggling to control your emotions, right? So say it very bluntly. Tell them, you look angry, you look like you're controlling things, but you look like you need help. How can we help you? And let them explain it to you. Okay. So be very direct in your questions, not rude, but very direct. So you look mad, you look upset, and then let them tell you if they are or if they're not. Don't tell me how I look. Okay, this guy is not receptive to my conversation. Or he'll say, yeah, I'm really angry, and I'll tell you why, and let them have their spiel, right? So don't rush them. Let them have their conversation, and let them talk. And if the talk becomes constructive talk, then you might be able to sort of verbally de-escalate the situation. There's kind of I'm trying to remember what text this is from. I'll see if I can find it for you guys, and I'll email it out to you. But there's a text on agitation, and they had I can't remember if it was 10 or 12 elements of conversation. So it was like respect personal space. So obviously maintain a distance. You don't want to get too close to that patient. So you don't want to risk injuring yourself. You also don't want to risk appearing like you're trying to intimidate them. So, give yourself, at least 2 arms length kind of thing. So give yourself some space. And that's, especially nowadays with COVID, you got to stay away anyways. But don't be provocative. Like don't egg them on. Relaxed, non-confrontational body posture. So don't be, crossing your arms. Don't be, standing above them, that sort of thing. So you really want to make sure that you're not being provocative. You want to establish verbal contact fairly early. And one of the things I find in these situations, especially if any of you have ever worked in Winnipeg, these situations I find escalate quick because there's so many people on calls. Which is good for safety, but at the same time can really agitate somebody who's already agitated. So if you can establish verbal contact and be the first person to speak to that patient and have everybody else just kind of quietly step back one extra step. If it's a one-on-one conversation, it tends to de-escalate things a lot sooner than if you've got, 10 firefighters over here having a conversation and 10 firefighters over there having a conversation and police officers, and there's lights flashing everywhere and there's traffic. And that's a lot of stimulus for this patient who's already agitated, and this can escalate it. So if you can have one person, fairly calm situation, be the only person who's talking, that really helps de-escalate the situation a lot more than if you have your partner asking questions to the patient and you asking questions, and et cetera, et cetera. They also recommend using really simple language. So not using elaborate medical terms or technical terms. So just make sure you're using really simple language when you're talking to people. Again, being really direct with their feelings. So what are you feeling? What are you hoping for? Right. So in this guy, he's probably not going to be too receptive, but you could ask him, what are you hoping for here? Right? You've cut this thing out of your chest, or you're trying to. What are you hoping to achieve? And maybe he'll tell you, I need to get this thing out of my chest so the government can stop watching me, and blah, blah, blah. Right? It might calm him down. Again, people want to be taken seriously. So make sure when you're speaking to them, or when they're speaking to you, that you're actively listening. And you can reiterate stuff to them. So after they tell you what's going on, you can say, okay, let me see if I got this straight. And then reiterate what they said so that they know that you're listening to them and you're having this conversation, right? Agree or agree to disagree is kind of So we shouldn't argue with patients, I think, is more so what I mean by that. So agree with them when things are correct, but don't argue or disagree with them. Just agree to disagree. So what do I mean by that? So if they say something that's clearly true, like, wow, the sky's really blue today. Yeah, the sky's super blue today, isn't it? Looks great. But if the patient says something that you absolutely don't agree with, don't start an argument. Just say things like, more like, you know what, there's lots of people who think the same way as you, right? That's not me saying I disagree. That's me saying, you know what, there's lots of other people who think the same thing as you. That sort of, it's not a disagreement with them, but it's sort of a way of letting them know that they're maybe not alone. So you don't have to disagree with them, or you don't have to agree with them, but just sort of agree to disagree, if that makes sense. So if they're saying something that clearly, is wrong, we don't want to start an argument. We don't want to escalate things. So you can just say to them, you know what, I'm sure there's a lot of people who feel the same way, who have that same point of view, right? Hope that makes sense. It's kind of a way of de-escalating an argument. Other couple things is to make sure you really set down the law, lay down limits. So explain to the patient, we're not going to accept any violence in here, okay? The police are here. If you are going to be violent, they're going to have to get involved, right? Sometimes that's enough for patients to sort of get it. Okay, I get it. If they're still having some clear thought, sometimes that's all it takes, right? Offer choices, right? Explain to your patient what you can do for them, right? And then debrief the patient and staff. So here's the thing, here's what we're going to do, okay? Explain it to them, debrief them through it. And same thing for everyone else who's there. This is what we're going to do. We need to do A, B, C, and D before we can get to, to the hospital, okay? Okay, that was a lot, I understand, but it's kind of important to sort of understand how to interact with these patients. And one more thing, I don't know if I mentioned, but never lie to them either. So you can disagree with them, or you can agree to disagree with them, but never lie. So never tell them, oh, you'll be in the hospital for like an hour. Don't worry about it. This will be quick. And then they're there for 5 hours and they get agitated again. So be as honest as you can all the time. Okay. If verbal techniques don't work, then we need to start looking at restraint. I'm not going to get into a big discussion about restraint. We don't have a restraint policy in Southern yet. I know Shared Health is working on something for the whole province. Some regions have it. Suffice it to say, police are there to assist with restraint if that's needed. Certainly, if you're being attacked, you can restrain them to protect yourself. But I'm not going to get into too much more about restraint than that. Okay, so let's go back to this gentleman here. So the police say they've dealt with this guy before. They've taken him to the hospital, and subsequently they've had to take him to a mental health facility. So we know that he's probably got some kind of mental health disorder, mental health crisis going on. So medications and allergies, we have no idea, okay? Because we can't really get much out of this patient. So let's do a differential diagnosis here. So you guys can chime in. What do you think are some of the leading causes for this patient? And then what are some other things that can cause agitation?
Patient quit taking their medications.
Yeah, sure. So maybe this is a patient who does have a mental health disorder and they've stopped taking their medication. What else could it be?
Maybe they took something new, or maybe their meds are no longer effective at that dose too.
Yeah, absolutely. Yeah, they've built a tolerance to it, or yeah, it's just not effective. What else could be going on here?
Withdrawal.
Could be withdrawal. Yeah, absolutely. Withdrawal from some kind of medication or illicit drug or alcohol. Yeah.
Sometimes it could be caused by the doctor just making a change to their medications.
Yeah, could be they've changed medications and they're reacting poorly to it, or they're getting a response they wouldn't have expected.
Maybe he's having a medical emergency like low blood sugar or something.
Exactly. Yeah, could be a metabolic thing.
It could be someone who's like known to police, but maybe undiagnosed by a doctor yet.
Yeah. So in this case, they say they took him to the hospital, and he was subsequently taken to a mental health facility. Now, I'm assuming the hospital ran all the tests they could and CT scans and whatever. I'm assuming they didn't just ship him out of there. So we're thinking this patient is probably, in this scenario anyways, probably somebody who does have maybe a schizophrenia, paranoid schizophrenia or something like that. So let's say we didn't know anything about this patient. He's brand new, police didn't know him either. What are other things that could cause this agitation?
Drug use, meth, psychosis.
Yeah, it could be a amphetamine-induced psychosis or some other drug. Yeah.
Maybe the government chip was real and it had some kind of a weird effect on him.
Maybe he's right. Yeah. What about, same things as seizures, right? So maybe he's got a traumatic brain injury, or maybe he's got an undiagnosed tumor, or an undiagnosed bleed in his brain, or an aneurysm, or something that's putting pressure in there. Maybe he's got some kind of encephalitis, like some kind of infection. Maybe he's hypoglycemic. I think somebody mentioned that earlier. Maybe he's had a stroke. So basically that AEIOU tips thing, a lot of that could apply here as well. So it could be psychiatric, it could be stroke, it could be an insulin issue, it could be an infection, it could be trauma, alcohol, epilepsy, et cetera, et cetera. So it could be a lot of things going on with this patient. We have a pretty good idea with this guy, what it is. We have been trying to talk to this guy for the last 10 minutes. He's just getting worse and worse. And he's decided to start throwing things at the police officers. So what do you think is going to happen now? What should we do for this person now? He obviously needs help. We need to be there for him, but he's not responding to verbal de-escalation, and he's definitely not going to respond to or cooperate with taking an oral benzodiazepine like Lorazepam. So how do we safely get this gentleman the care that he needs? What do we do next?
Ask police for assistance, restrain him.
Yeah, ask police. So the police in this case they're trained in how to restrain people. They're going to be able to do it safely. So we'll get the police to restrain the patient, and they do that for us. And he's thrashing about, he's kicking, he's fighting, there's no way for you to get a blood pressure. Now what do we do?
Try get an IV.
Hit him with Midaz.
Hit him with Midaz. So we can try to do an IV for sure. So first thing we want to do is sort of try to rule out hypoglycemia if we can. We might be able to get a blood sugar even though the patient is thrashing about. Just depends on how he's restrained. So let's try to rule out hypoglycemia first. And let's say in this case, we managed to do that. So he's not hypoglycemic. But we have no other way of assessing this patient. He's thrashing about. And the risk in patients who are restrained and start to thrash is they'll develop things like rhabdomyolysis. They can get asphyxiation. And there's been patients all over the world who've been restrained and ended up dying because they get into this agitated state. So we want to calm this person down before we get to that point. So the consideration of oral lorazepam is probably out in this case. He's not going to cooperate with that. So we're going to want to consider midazolam or lorazepam. So this here now is at the ICP level. And I know one of the questions that comes up is if you read the midazolam care map, which I'm going to open here, the intramuscular midazolam is in pink, and it says chemical restraint when IV access is not rapidly or safely available. However, it's not in the care map yet. And so I clarified this with Dr. Hurd this week, and it is the care map that is the enabler, which means the care map allows specific training levels to do specific things. And this one has not been revised. And so today, if this was to happen to you and you were a PCP, it wouldn't be in your scope to do it, to give the intramuscular midazolam here. Okay, so we'll leave it at that for now. But midazolam is the choice here. We give that intramuscularly. How long do we say it would approximately take for that midazolam to kick in intramuscularly?
15 minutes?
Yeah, it's about 15 minutes. Sorry, Velma, did you have an answer?
Saying the same thing.
Okay. Okay, perfect. Yeah, so roughly 15 minutes. So just know that when you give it, you're not going to get an immediate response. It's not like on TV where, you watch the old episodes of Grey's Anatomy and they give it and the person right away is on their back. It's nothing like that. It's going to take some time. You're going to start noticing, after 5 or 10 minutes, they're going to start to be maybe slurring their words, being a little more relaxed. And then after about 15 minutes, you'll start to see more of a progression. It's not going to be this guy who's screaming and yelling at cars all the way down to, kitty cat who's napping. It's going to be a slow progression sort of downwards. Okay. Consider physical restraint. We've kind of already done that in this scenario because the patient was being violent. But you may have to do it afterwards if you do manage to give somebody midazolam and then they become, they're still being violent. You may have to restrain them afterwards. But again, do that with police as soon as you can, if it's necessary. If you're suspecting alcohol withdrawal, then you would go to that care map. And then there's, for the ICPs on the call here, there's the consideration of haloperidol. So a question we get lots is, can I just give midazolam and haldol at the same time? Can I put them in the same syringe? I'm probably not. It's not best practice. Certainly, I've seen physicians do it. It really just depends on the patient. So, actually, what I'll show you guys, this might not be easy to see. If you press Control and zoom in on your screen, you can actually make this bigger for yourself. This is kind of a table that is used. I think I found this in Up-to-Date a long time ago. But basically, it sort of explains what you would use as sedation for patients who are agitated, depending on the situation. So, of course, at the very top, you want to ensure that everyone is safe and try to use verbal techniques, and then place physical restraints if necessary, and then get them on a monitor if you can. Then we need to decide if rapid sedation is needed. So if they're calmed down enough, then we'll just assess them for causes of agitation. We'll take vital signs, we'll check their blood sugars, etc. If we need to sedate them, excuse me, then we're going to look at these boxes down here that kind of explain different situations. So if I had a severely violent patient, like in this scenario here, the guy's starting to throw rocks at the police officers, he's cutting himself with broken glass, then I'm probably going to go ahead with midazolam plus the haldol. Probably going to use both. If he's that severely violent, the midazolam by itself is going to take some time and probably not going to be as effective as if we use both together. So I'll probably use both in that scenario. If I have a patient who's intoxicated with a CNS stimulant, or it's an undifferentiated patient. So let's say it's a patient we have no idea why they're agitated. Then probably just the midazolam IV, or if they're cooperative, you could go with the oral Lorazepam. And then there's a couple other scenarios here. This one here would say only haldol for people with intoxicated on CNS depressants. It's not in our care map, but you could certainly, as an ICP, you could talk to OLMS. You're probably better off to just go with the midazolam first and then the haldol. And then the same thing if you have patients with known psychiatric disorders. They're saying you can use haldol by itself. Again, what we're trying to achieve in the field is safety for the patient. So we want to achieve a level of sedation prior to giving the haloperidol. So my suggestion would be give the midazolam first, give it a chance to work, see if it helps you out, sedate them to a point where you can assess them a little better, and then you can decide if haloperidol is the way to go. We're not talking specifically about haloperidol today because it wasn't part of the case study, but certainly you want to start with that midazolam first and get a level of sedation before we start giving haloperidol. In your severely violent patient, you may need to give both, but again, I would give the midazolam first and then follow it up with a Haldol if you can find, some answers before you give it. But anyways, that's one way of thinking. To me, it's just the way to go. Try some sedation first, and then decide if you need the antipsychotic. Okay. So for this guy here, the next steps, again, we're going to go with the midazolam. The dosing is the same as what we mentioned before. I'll maybe just pull that up one more time here for everybody. So if we're looking at the dosing, if we're giving it intramuscularly here, in this scenario, we decided intramuscular is probably the safest way. Then we're looking at 0.2 milligrams per kilogram for this patient with a single max dose of 10 milligrams. And you look at this guy, he's probably about 180 pounds. So you're looking at 85 kgs or something like that. So definitely going to be exceeding that max dose. So 0.2 milligrams per kilogram for this guy. We're going to give him the 10 milligrams, and we'll give it IM. Okay. And that again is at the ICP level. The PCPs, if the patient was being cooperative enough, you could go with the oral lorazepam today. If the care map is revised, then it'll show it on there. But as it is today, it's the midazolam is at the ICP level. Okay, so we decide to give this patient midazolam. Oh, did somebody have a question?
I had a question. How involved does EMS get with restraining? We just recently had a call very similar to this, but it wasn't due to quite not as serious, but we're talking about a 120-pound youth that 2 police officers couldn't control. And it took both medics at the same time to get the person quiet enough that they could put handcuffs on them. Like they didn't tase the individual, but
yeah.
And in fact, then it took 3 police officers after that. Basically,
I'm going to give you a non-answer. Yeah, I'm going to give you a non-answer. Today we don't have, at least in our region, we don't have a restraint policy, and I don't have any legal opinion from our legal department on what exactly we can and can't get involved in. So I'm not going to give you an answer. I don't know the answer, to be honest with you.
We could tell that the police officers were having a hard time and they weren't getting anywhere. So we basically asked, do you want us to help you? And they said yes.
Yeah.
So then we
and that's fair. Certainly if someone is going to get hurt, or you're going to get hurt, you have a right to assist. As long as you're not using excessive force, you have a right to protect yourself. So that'll be my answer for you. I was an auxiliary constable. For those of you who don't know me, I was an auxiliary constable for 4 years, which is basically like a volunteer police officer kind of thing. I don't know. I don't even know how to explain it. But anyways, the biggest fight I ever got into was a 16-year-old female who was like 120 pounds and just wasn't feeling pain. So just scrap. And those can be really dangerous situations because someone can get hurt fairly quickly. And in the attempt to restrain that person, you can hurt them too. So, like I said, everyone has a legal right to defend themselves if they're being attacked, as long as you don't use excessive force to defend yourself. But as far as what's our role in restraint, I don't have an answer for you because we don't have a policy and I don't have a legal opinion. So I really can't give you an answer. Sorry, I realize that's
you say our role was basically sit on the child. It took 4 of us.
And I understand we're trying to help the police, but I can't give you. I can't give you a legal opinion or an answer because I don't have it. So it seems like a cop out, but I don't want to give you the wrong answer and have you say, "Oh, Jerry said we can do this," when really I don't even know. So I can't give you an answer. I don't know. Okay, so we give this person midazolam, and about 15 minutes later, they're relaxed to the point where they're starting to ask where they are, and wondering what happened, and starting to respond more to your verbal discussions with them. So what would be your next steps now?
Reassessment of the patient.
Yeah, basically start from scratch, right? So reassess LOC and ABCs, do a quick head to toe. There might be things you missed before. We saw that obvious laceration. I'm hoping by now we've done something about that. But if we haven't, let's address that. And let's look for any other injuries he may have caused, during the scuffle with the police or, prior to our arrival on scene even. And then let's start getting some vital signs, right? So I'll give you guys a quick set of vitals. I realize we're past our time here, but I'll give you guys a quick set of vitals. You have a blood pressure of 136 on 74. Your O2 sat is 95% on room air. His pulse is 124. It's regular. Sinus tach. No ectopy, no PVC, no nothing like that. His respiratory rate is 22, regular. His temp is 38.3. And his blood sugar is 4.8. Okay, anything in there jumping out at us, making us worry?
Temperature is a bit elevated.
Yeah, his temperature is a bit elevated. Can anybody tell me why that might be?
Probably from the struggle and the fight.
Yeah, it could be from the struggle or the fight. It's possible that he has an infection, right? And maybe the infection is what's causing his drugs not to work the way they should. That's possible. But certainly you'll get patients who, they've been so tense for so long and their muscles have been vibrating so much, and then they get into a scuffle like this, that can elevate your temperature as well. So a couple things to keep in mind. Any other vital signs that are jumping out at us? I think the rest is pretty expected, right? Like you're expecting this guy to be tachycardic. And he's going to have a slightly elevated respiratory rate, right? He's pretty amped up. His blood pressure is probably not what I would expect for a 24-year-old, maybe a little high, but that's kind of expected in this situation too, right? He's all jacked up from this agitated state that he's in. So nothing too alarming, but we're definitely going to want to watch his vital signs for sure. And what? Oh, sorry. Go ahead, Bella.
With being regular and tachy, like sinus tachycardia and that, with using the midazolam, would that not be slowing down even for his heart rate as he relaxes? Wouldn't that be lower already with the midazolam on board?
As he relaxes, his heart rate should come down for sure. It probably has come down, to be honest. He was probably higher than that before. So at this point, it's our first set of vitals. We're gonna check the trends. So we'll check him again in 5-10 minutes and see where he's at. Hopefully that's come down some more and his respiratory rate has sort of settled down. If we've achieved enough sedation, right? If we haven't achieved enough sedation, we may not see much change at all. So again, it's about that constant monitoring of that patient. Okay, so we got some vitals. I think we're pretty happy. This guy's calmed down to the point that even lets you start an IV on him. And now we're ready for transport. So he is handcuffed to your stretcher. The police say, "Hey, can we get our cuffs back?" What do you guys think?
I would say no, keep him on. And you can come with us to the hospital.
Does everybody kind of agree with that?
Yeah,
Drinks and have the police still come too?
they can come.
They can come. I would agree with that. I think, these are so unpredictable. And in the back of an ambulance, such a small space is pretty hard to maintain a distance or to escape, especially when it's moving. So probably a good idea if you can convince the police officer to hop in the back with you and leave those cuffs on. How should you cuff the patient to the stretcher? Both arms down, one arm up, both arms up?
One arm up, one arm down, and then they can't really swing at you as easily.
Yeah, so that's kind of the way. Usually one arm over their head, so restrain them to the top of the stretcher, and then one arm down, and then they can't actually sit up like that, right? So it's hard, and it's hard for them to swing at you. So yeah, usually that's the way to go. If it's going to be a really long transport, you might want to help. You might want to get the police officer to change that position for you. So move the other arm up and one down, just so that they're not stuck in one position for a really long transport. But yeah, usually one arm up.
Thought with doing the restraints, like, okay, one arm up, one arm down is how you're trained to do it. But I thought in our care maps, it was wanting us to put the patient on their side.
Yeah, again, we don't have a restraint policy. So, I mean, if you can get them on their side, prevent aspiration or whatever, depending on the scenario, right? Then, I mean, yeah, whatever position is going to be safer for the patient. But again, we don't have a restraint policy, at least not in the South. So whatever your restraint policy says, if you guys have one, then certainly go with that. But. Okay, transport. How are we transporting this gentleman? Is emerge, non-emerge, amber, in between?
I'd go non-emerge. You don't want lights and sirens and get them aggravated all over again. You never know what's going to aggravate them, right?
Yeah, I think that's pretty fair. Does anybody disagree with that?
I agree. Don't see any life-threatening issues at the moment and can always upgrade if anything changes as well.
Sure. Yeah, I think that's fair. His vitals are all fairly good. We're not seeing any deadly bleeds or any injuries that we'd be super concerned about at this point. Certainly, if we found something in our assessment, we would definitely upgrade this. But at this point, it appears like it's the agitation that's the main cause of our interaction with this gentleman. So, yeah, I think we'll probably go without lights and sirens. But like you said, if we need to upgrade, we certainly can. We don't want to aggravate this patient more. So. Okay, any questions on agitation, seizures, benzodiazepines, how benzos work? I'm not that good an instructor, so there must be some questions.
I have a question, but it's not really pertaining specific to this.
Okay.
Point for the colleagues, is this something as an education you think we can use for this, and how would we go about doing that? Because like I'm in the north, but you're in the south.
So I missed the first part of your question, Velma. Can you ask it again?
With us being underneath the college now,
yeah,
and we can use different things for educational purposes, but some things have to be documented as in who the instructor was and things like that.
Yeah. And you're asking if you can use this? Yeah, I'm certainly, if people want to use this as, towards the college, that's totally fine. Yeah.
Also, Jerry, I think you're being modest because you're a pretty good instructor as well. So I just want to thank you for that and for taking the time out of your day to educate all of us and becoming better medics as well.
Oh, no problem. Is it Brittany? I don't know where you're from, Brittany, but you're my favorite student now, and you get
Brittany's
extra
a Budney,
points.
Portage. Woo.
Oh, Brittany's a Budney. Oh, okay. Well, you get extra points.
Thank you. I need them at this point.
Cool. Well, I want to thank those of you who are not from Southern who joined us. I think that's really cool, and I hope we keep doing this. As you guys know, we have sessions every couple of weeks. I'm going to stop sharing here so you guys can just look at my ugly face instead of my presentation here. Yeah, so you guys can you can certainly join us every couple of weeks. I think our next one is not next Thursday, but the week after. I don't remember the topic off the top of my head now. Oh, pain and pain management, I think is what we're talking about. So yeah, anyways, it's nice to see all of you. If you have questions, certainly you can send me an email, or you can email your own clinical manager. They'll have answers for you. I hope this worked. If there's things about this that you didn't like, or stuff that you wanted more information on, I mean, we can talk about this forever, but we tried to kind of cut it down to what was really important as far as benzos go. But if there's anything you thought of that you were hoping we could talk about, then yeah, let me know. Send me an email, and we can work on that in the future when we start doing more of these sessions. So in the meantime, that's all I have for you. It was really nice to meet all of you, and thanks for coming by.
Thank you very much.
Thanks, Jerry.
See you guys.
Thank you.
Hey Jerry, it's Dylan here.
Yeah.
I just had a quick question. Would
Sure.
you be available for a phone call quickly?
Yeah, where are you right now?
I'm just in Swan Lake.
In the station?
Yeah.
Yeah, for sure. Give me like 10 minutes and I'll give you a call there.
Okay, thank you very much. It does regard the phone, the presentation here. So.
Cool. Yeah, for sure.
Okay, thank you very much.
Hey, Jerry, it's Colleen.
Hey, Colleen.
I have a question for the intramuscular.
Yeah.
You know, the onset of midazolam is about 15 minutes. Now, in the care map, it says repeat once in 10 minutes. So
Yeah.
you take it with a
Yeah,
grain of salt.
that's fine. If you're really not seeing, you're going to start seeing some effects before the 15-minute, but the actual, like the onset where you start to notice any real sedation is going to be 15 minutes. So if you're really not seeing anything in 10 minutes, you're okay to go ahead and give a little bit more.
Okay. I just wanted that clarified. Awesome.
Yeah.
Thanks so much, Jerry.
See ya.